Hi, everyone. Today's lecture is going to be about the problems that we see in labor and delivery, and we're going to talk a little bit about some of the procedures as well. So we have learned in a previous lecture what to expect, what's normal, and now we're going to use that foundation to build on it and start looking for the things that are abnormal. Okay, let's get started. Okay, so for your reference, this is chapter 21. A little bit of the disease processes from chapter 20 are included in here, and our obstetrical procedures. So pregnancy complications that can lead to delivery complications. We've already talked previously about placenta previa, placenta abruption. Remember the cardinal signs of both of those. Hypertension, we're going to spend an in-depth amount of time on that today. And then we have previously mentioned gestational diabetes and how it affects the newborn, but now we're going to talk a little bit about some of the issues it can cause, conditions it can cause in actual delivery. So the complications that we're going to focus on today: cord prolapse, shoulder dystocia, fetal distress, amniotic fluid embolus, and hemorrhage. And thankfully, all of these are on the fairly rare side. I'm not going to say that you won't see them, but especially with this one, it's on the extremely rare side. So we are talking about the worst case scenarios. So if you happen to be a pregnant person that happens along this video, know that we have to learn about these things, but these are not common experiences. So don't let it frighten you. As I move to the next slide here. So this slide, actually, anyone that works in maternal health should be very concerned about this information. For the last, since 1990, we have seen a steady decline in the rate of maternal death throughout all of our developed regions. We're talking about Europe and everything that's not a third world country. But here in the United States, we've actually seen an increase since about 2005. We've seen an increase in our maternal death. And so there have been a lot of very intelligent people getting together, trying to figure out what in the world are we doing that is contributing to this increase in maternal death. And that's really beyond the scope of this class. I just want you to have this information. We could spend a whole semester talking about some of the procedures and policies that are put into place trying to decrease this trend. This is another interesting statistic that has come out in the last few years, is that we see, looking at the different race and ethnicity of our maternal death, and you can see across the board, we always see a higher amount of maternal death in our African American Black population. And again, there's been a lot of effort trying to figure out what we're doing in this arena, and a lot of work is being put into that specific arena. And I'll just put a little plug in here. We are completely underrepresented in the maternal child health field for our African American nurses and nurse practitioners and providers. And so if you are in that group and you are interested in the maternal child health field, we desperately need more representation. There was an interesting study that was put out that women and babies of color who are taken care of by women of color actually have better outcomes. And they don't know exactly why, but they do. It is an interesting statistic that's out there. So looking at California, so this red line here is the rest of the United States, and you can see that this is a maternal deaths per 100,000 live births. And in California specifically, we have decreased our maternal death. And the big reason behind this is because we have something called CMQCC, California Maternal Health Quality Collaborative, who does a lot of research and putting out toolkits to help us decrease the big issues surrounding labor and birth. So for instance, they did one about decreasing the primary cesarean section rate in low-risk women, and they've done one about hypertension, and they've done another toolkit about decreasing early delivery, early elective delivery. So it's available for anyone to see on the website, CMQCC. Highly recommend you spend some time. There's a lot of very intelligent people working for that organization. So these are some of the causes of death. This stopped in 2016, but there is cardiovascular conditions have surpassed obstetrical hemorrhage. As you can see, obstetrical hemorrhage is over here. And so these are the two that I've heard most about during my 20+ year career. These are the conditions. And so that's why we're going to spend some time talking about our hypertension and the hypertensive disorders that lead to that, because we have seen an increase in those, and those are one of our big issues surrounding our maternal death. So leading right into that, this is a group of all the different hypertensive disorders that go together. We used to think that one would lead to another, would lead to another, would lead to another, and that's not necessarily true. So gestational hypertension is hypertension that has been diagnosed before the 20th week. 20th week is kind of the landmark. And gestational hypertension is after the 20th week. Chronic hypertension is before the 20th week. So if you have hypertension diagnosed before your 20th week, you had hypertension before you were pregnant. It was just undiagnosed. And gestational hypertension is after the 20th week. And then we have a condition that is called preeclampsia. And what we really know is this is really a placental problem. And I'll get more into that in a minute. And preeclampsia can lead to eclampsia. So this used to be called toxemia, and then they changed the name. And it's something that we read about even in our very old accountings of maternal death. And most likely it was preeclampsia at that point, just based on the descriptions. But preeclampsia can lead to eclampsia, and we're going to explore these more in depth in just a minute. And then we have chronic hypertension with superimposed preeclampsia. So this is where you already had hypertension and you develop preeclampsia on top of that, which you are at a higher risk to do. So this is just a spectrum of all the different conditions. It kind of shows you that there's lots of things that go along to, in these conditions. And this is a lot of what we're looking for when we're doing our prenatal care. And most of those warning signs that you learned several lectures ago have to do with this and these conditions. And here is that CMQCC, California Maternal Quality Care Collaborative. This is straight from their toolkit. So some of the risk factors that predispose a woman to develop some of the cardiovascular hypertensive disorders are listed here. Prima gravida, which we know is the first pregnancy. If there's any diagnosed chromosome abnormalities or congenital anomalies in the fetus, multiple gestation. This is an important one. If there's a history of preeclampsia, a family history, first line relative, we are concerned because we think there might be a genetic component to it. And like I said, it is a placenta problem. We'll talk more about that. Chronic stress, extreme ages, less than 20, greater than 35, any use of ovulation drugs, a history of diabetes, hypertension, or renal disease, obesity, and lower socioeconomic status or poor nutrition. So these are some of the toolkit recommendations. So I don't want to get caught up on the specifics of these ranges compared to what your textbook says. This is coming out of the CMQCC toolkit, which were recommendations, and sometimes the textbooks and even your policies, wherever you're practicing, may be a little bit different. This is just a recommendation. So any systolic blood pressure over 160 needs to be repeated. And if it's still over 160, then there needs to be some sort of treatment. These are alternative triggers. So sometimes you'll see those ranges a little bit lower. Any diastolic blood pressure over 110, again, needs to be repeated in about 10 to 15 minutes and then treated if it stays over that. And we know by actually diagnosing and treating these things early, we have better outcomes. That's part of what they found in their research. So here is a description, and you can stop this video and read all of it. I'm not going to read all of it to you, but here you have a classification. So chronic hypertension is prior to 20 weeks, like I mentioned, and gestational hypertension is going to be after 20 weeks. It may evolve to preeclampsia, and this is really a retrospective diagnosis. Preeclampsia is after 20 weeks, and here is the criteria. If you have a blood pressure greater than 140 systolic or 90 diastolic, or proteinuria in either a protein creatinine ratio and or a 24-hour urine specimen, then it is diagnosable as preeclampsia. And then eclampsia is the presence of new onset grand mal seizures. Here are continuing symptoms, the rest of this. And then we also have hemolysis, elevated liver, low platelet, called HELP syndrome. And this is a subset. Some people with severe preeclampsia will move into this subset and some will not. Talking about getting vital signs, it's so important that we do it appropriately. So for instance, we need an appropriate size cuff that is fitting this patient in order to get an accurate vital sign. We also need to make sure that she is sitting, relaxed, without her feet crossed, preferably has been sitting for a few minutes, and not talking while we are obtaining that blood pressure. Now, if you've been practicing for a while, you probably have heard people say, turn her to her left side and take it again. Well, we don't want to do that anymore. An accurate blood pressure needs to be just in the position the patient is in. We don't want to try to influence getting a lower blood pressure. We actually want to diagnose and be ready for it rather than trying to mask it. And here is a picture of assessing edema, because the other thing that goes along with preeclampsia, this is a sign of it, is edema. Now, women will have edema when they're pregnant. We've already looked at the physiology of that. But if it's pronounced and comes on suddenly, especially if it's around the face or the eyes, we know that is a sign of preeclampsia. So you can see here, this is actually the same woman a week apart. So here she has a little bit of normal swelling. She's been on her feet all day. And then this is what she looks like a week later. When you start having pitting edema, that is one of those warning signs that we need to follow up on, because it may very well be related to hypertension or a preeclampsia diagnosis. And then this is looking at if you were to actually use your finger to assess it. And then understanding how to do deep tendon reflexes, very important. Okay, back to deep tendon reflexes. Sorry for that interruption there. Knowing how to do these is a very important skill. If you do not know how to do deep tendon reflexes both on the knees and on the arms, you'll need to go to YouTube and see some videos. I actually have some on my one of my curated video lists, because understanding the reflexes and knowing how to do them and assessing them is an important skill to look at how excited the nervous system is with these diagnoses of hypertension and preeclampsia. Also, if you're going to be giving the medication, magnesium sulfate, we need to be able to assess this in order to know if she's becoming magnesium sulfate toxic. And so this is an essential skill to be able to do in labor and delivery. And so make sure that you know how to do this. And understanding the protein creatinine ratio, here is actually the formula, but you can go to this easy calculator that will let you determine it if your labs are not creating a protein creatinine ratio for you. And this is a diagnostic. This is the gold standard diagnostic to determine if there's protein in the urine. Now, some places, critical access hospitals and whatnot, may still be using urine dipsticks, and anything 2+ or more is considered positive. But remember, protein is in the urine could be from blood, because blood is protein. So if you are dipping the urine and you have blood and you also have protein, you can't be sure that you're getting an accurate reading. That's why we're doing this calculation now. This is a fantastic flyer that you can give to your patients. It provided it here. It's provided free. You can order them. It's English on one side and Spanish on the other. And look at these signs. Look at these things that we need to report. And remember our warning signs that we talked about previously. Headache that doesn't go away. Nausea, vomiting, can't stop. Seeing spots or having visual disturbances. Swelling in your hands or face. Gaining more than 5 pounds in a week, usually associated with edema, and extreme pain from anywhere. So looking at the management of gestational hypertension, if it's preeclampsia, depending on whether it's considered mild or with or without severe features is how it's labeled nowadays. So if it's without severe features, then we might look at bed rest at home. Of course, we're going to have to give good education about that. Daily blood pressure monitoring, and the blood pressure cuffs that they use at home are not always very accurate. So we have to warn them that if they get readings that are outside of normal, we want them to come in and have it looked at by a professional, just because sometimes those machines, if they're not used exactly right, or if they're not put in the exact right position, they don't give a real accurate reading. And we're also going to be talking about fetal movement kick counts. And we've talked about that in a previous lecture about the importance of paying attention to fetal movement, because when a baby becomes stressed, then the first thing it's going to do is slow down all of its major muscle movement, and we will see decreased fetal movement. And it might become stressed if mom's blood pressure is so high, because you've got that narrowing and constriction of those blood vessels that are going to the placenta, which of course is where the baby is getting everything it needs. So we will probably be looking at an NST and a biophysical profile weekly. Make sure that you understand both of those tests very well. Hospitalization, if we move to hospitalization, then we might consider doing magnesium sulfate. I've done a complete other video on medications. I highly recommend that you spend some time there. If you're in my in-person class, it will be one of your assignments. If you're one of my online students, then you definitely want to take a peek over at that video. It's got some great information in there for you. If it's preeclampsia with severe features, this severe features would be any of those signs and symptoms that we talked about, then we are going to be hospitalized. Antihypertensive agents are going to be utilized, so we'll have parameters to keep those blood pressures. We might consider induction with Pitocin, oxytocin, magnesium sulfate for seizure prophylaxis, and preparing for birth. So a little bit about the magnesium sulfate. In some older texts and in some places, you will see that magnesium sulfate previously was used as a tocolytic to stop preterm labor. And occasionally we will still utilize it to try to hold off preterm labor, so that we might be able to get some other medications on board for lung development for the baby and whatnot. But in this particular instance, the reason why we give magnesium sulfate is for seizure prophylaxis, because it decreases the swelling in the brain, or the swelling that in the vessel that can cause swelling in the brain that will lead to eclampsia. So a side effect of magnesium sulfate is lowering the blood pressure because it causes vasodilation. But that's not why we're giving it. We're not giving it to lower the blood pressure. The blood pressure is not the problem. The blood pressure is a symptom of the problem. So as I previously alluded to, the current science that is looking at preeclampsia says that it's a placenta issue. It's a placenta disease, in that the woman's body is responding to the placenta being in her body. Almost like, simplified terms, it's almost like an allergic reaction response. It's It's a hypersensitivity to that placenta, which is why we think there's a familial relationship there. So if your mom had it, there's a good possibility that you'll have it as well. So looking at this, it's a inflammation problem. And that's why we see swelling. And that's why we see high blood pressure, which is swelling in the vessel. And that's why we see blurred vision, which is swelling in the vessels in the head, causing excess pressure. And that's why we see kidney issues and liver issues, because all of it has to do with inflammation. So just a little disease process there for this condition. So if we move to eclampsia, it means that we have gotten to the point of seizing. And again, we want magnesium sulfate on board as soon as possible to try to get that swelling down to stop the seizure. And then once the seizure is controlled, we are going to get this baby out. And the treatment for this disease process is to get the placenta out. There is nothing else that we can treat the symptoms, but we cannot fix the problem until the placenta has come away. So these are some nursing assessments that we do. You can just take a look at this. If we have preeclampsia without severe features, these are the assessments that we would do. And then management. If it is early on and she is diagnosed with gestational hypertension, we are going to be looking at her nutritional intake. We're going to be watching her blood pressure very closely. Nutrition intake, we're going to be decreasing salts and anything else that we would decrease in those people that have cardiac issues. We're also going to be watching her weight, edema, urine for protein. And these are all the things that we are doing in our prenatal visits. All of this is looking for signs of preeclampsia. Okay, this is a great little slide that has a frequency of nursing assessments. So looking for if you have a hospitalized patient, these are for patients not on magnesium sulfate. So if we have a patient on magnesium sulfate, we're going to be looking at these things much more frequently and per policy. So here are triggers to report. If you're caring for a mom that has signs and symptoms of preeclampsia, all of these are triggers, obviously increasing blood pressure, taking an accurate blood pressure, headache, altered level of consciousness, including visual disturbances, blurred vision, floaters, spot, blind spot, upper abdominal pain, urine output, and cough. These are all things that we need to be paying attention to when they're caring for our pregnant moms. Now, preeclampsia can develop very suddenly and very quickly. So these are things that maybe you don't have any signs and symptoms, and then a few hours later you do have signs and symptoms. So that's part of our job. This is a great little slide. This comes from CMQCC. It's talking about the actual dosages of the medications. Again, I've done a complete different medication video, so you want to spend some time there, or you can pause the video and take a little look here. Magnesium sulfate is a high-risk medication, meaning it needs an independent nurse double check. So 2 nurses need to independently do all of their 8 rights on the medication. And it is something, because we're using it in such high dosages in labor and delivery, we need to pay very close attention to how the mom is reacting. So according to your policy, you're going to be watching very closely her lung sounds, her urine output, her O2 sat, and her deep tendon reflexes, because all of those will lead you to predict that she's moving into a magnesium sulfate toxicity. And everyone that is on magnesium sulfate needs to have calcium gluconate readily available. Readily available is not down the hall in an Omnicell or a Pyxis, whatever it is that you're using. Readily available is in a locked drawer in the room or in a lockbox in the room, so that it can be given very quickly. And you know, we like our acronyms, so here is a nice little acronym to remember magnesium sulfate toxicity. When you're looking at a patient's environment, if she is preeclamptic or on magnesium sulfate, she needs to have lots of things available to her. You want to make sure your oxygen and suction setup is there. How often have you walked in a room and found that the oxygen tree is missing? So you want to look at that before you need it. You also want to check these things and make sure they're actually working. We want to keep her room as quiet as possible, turn down the television, decrease the amount of visitors, because all of that excites the nervous system, which can actually cause her to go into a seizure. In fact, the first eclamptic seizure I ever saw was because the nurse that was helping me, or I was helping her, slammed the door, and then immediately the patient started seizing. So making sure that she has side rails up that are, all the normal safety conditions, but we also often still have policies that want us to pad these side rails in case she starts to seize, and that so she doesn't cause herself injury. But as the nurse coming on, the nurse taking care of this patient, assuming care of this patient, it is her or his responsibility to actually check that all of these things are present and available to them. And you don't want to be the one that didn't check and then needs them. And then I mentioned HELP syndrome is a subset of preeclampsia. And so some people will advance into HELP. And again, it stands for hemolysis, elevated liver, low platelet. And these are diagnosed by certain lab tests that we will do to be watching for this condition. If it advances to HELP syndrome, we have to get this baby out, regardless of the gestation. This baby's got to come, because it is truly the mom's life versus the baby's life at that point. And of course, we'd like them both to be healthy. So lab tests, pay attention to those labs that were given to you in your lab resource. And then you'll have a good list of all the labs that we're looking for when we are looking for HELP syndrome. And these are some of the treatments that may be needed. We might need steroids for lung development, depending on the age of the fetus. We will have magnesium sulfate on board. We're going to be continuously monitored. We might be giving platelet transfusions or blood transfusions. And these women often end up in the ICU. They need a higher level of care than what can be treated in labor and delivery. And so once they're delivered, they frequently will head to ICU. And they're at high risk for hemorrhage as well, which is one of the things that we're going to be looking at in just a moment. So when we take care of our patient, I've mentioned in the normal birth video, all the things that are normally supposed to happen, we're always doing assessments, and we're looking for the potential for these problems. So we're always doing a hypertension preeclampsia assessment on a patient. We're always doing a labor or birth dystocia, which means difficult. Assessment on the patient, and we're always doing a hemorrhage assessment on the patient. And it's not yes or no, it's low, medium, or high. And we'll spend some more time looking at that. So now we're going to move into some of the delivery complications. You've seen this picture before. There's actually a video on the circulating on the internet. This baby was born by C-section, and it's still inside the sac, and you can kind of see what it looks like on the inside for just a moment before they break the sac and this baby starts to breathe. So again, dystocia, the definition is slow or difficult labor or delivery. So we might have a labor dystocia, or we might have a birth dystocia, often called a shoulder dystocia. And the risk factors for any dystocia is epidural anesthesia, epidural analgesia, and that's because that can slow things down and make things more difficult for us to actually push this baby out. Multiple gestation, if you have more than one in there, it makes everything a little harder. Hydromenos, whether it be oligo or poly, can increase your risk for this. Maternal exhaustion, ineffective maternal pushing, which may be from maternal exhaustion or from epidural anesthesia. That fetal malposition, again, that occiput posterior or OP or sunny side up, all of those mean the same thing. And that's when the baby is not in the optimal position for delivery. If you have a longer first stage of labor, we are suspicious. That first stage is that dilation of the cervix and dilation and effacement of the cervix. And so if that's longer than expected, we're suspicious that we might have a second stage dystocia. So we're on the lookout for that. Someone that has a short maternal stature or has never had a baby before could potentially have issue pushing their baby out. So we're always on the lookout for that. Fetal birth weight over 8.8 pounds or 4,000 grams. That increases our risk of having a birth dystocia. If we've actually are diagnosed with a shoulder dystocia, abnormal fetal presentation, or anomalies in that fetus. Other risk factors: maternal age over 35. People often ask me why, and it's because our bone structure starts to calcify a little more. It's not nearly as flexible as it was when we were younger, and so sometimes we see issues with that. High caffeine intake, obesity, gestational age over 41 weeks. If you have infection, chorioamnionitis, chorioamnion being the sac, itis being inflammation, ineffective uterine contractions for whatever reason, maybe it's oversaturated with medication like oxytocin, or if the baby is at a high fetal station, so high up in that pelvis in those negative numbers, -3, -4, at complete cervical dilation, we're suspicious that maybe the reason baby's not coming down is because it doesn't fit, or sometimes it has a short cord and it's holding it up. But anyway, all of these things make us suspicious that things are not moving as designed. So these pictures are pictures that you're typically used to seeing: women in bed, laying on their back, laboring in bed. If you were to bring a mom into a labor room and she's unmedicated, this is the last place she's going to be. She's not going to naturally want to go to this area. So in order to facilitate good fetal positioning, we want to use these positions. These are the things we want to see. We want you to use the bed as a tool, not as a hindrance. And so I talked about this in my last video, but spend some time learning these different positions and the things that we can do to help get these babies out. This has been revolutionary in the labor and delivery units. When labor and delivery nurses started taking spinning babies classes, we started doing counts of how many times you use the spinning babies techniques and how many vaginal deliveries versus C-sections we had based on that. It was phenomenal, and that happened all across the country. So again, utilizing all those different positions, helping to get that baby into the most optimal position. If you're looking at modern day pushing, this is what you're used to seeing, right? Mom flat on her back. She's actually pushing uphill. In order to get this baby through that pelvis, she actually has to push that baby uphill. Think about those cardinal movements of birth as that baby moves its way down. So utilizing an upright technique is going to be more effective to getting this baby out than this technique. When we are doing our nursing assessment for potential shoulder dystocia, these are the things that we look at. If she meets any one of these criteria, she is now at high risk for shoulder dystocia. And by knowing this ahead of time, we can put some things into place. So for instance, you probably want NICU in your delivery, and anesthesia to be made aware that there's a high risk for shoulder dystocia. You want everyone in the room to have that situational awareness so that we can be prepared to deal with it if it happens. Looking at shoulder dystocia, this is the way the baby has to navigate through that pelvis, but if we have a shoulder dystocia, this is what's actually happening. The shoulder is getting wedged up here underneath the bone. And when that happens, here's a little algorithm, things that we would do to help get this baby out. Now this happens, I'm not going to say commonly, but it is a frequent occurrence. And there are certain tools, a series of events that the nurse is going to take and a series of events that the provider is going to take. So this is what's actually happening. This shoulder is wedged up underneath this bone, and it needs to turn so that it can decrease its diameter and slip right out. I'm going to go ahead and point out here, this is the clavicle. And sometimes if these shoulders are so broad and they cannot get this baby to turn, what will give away is actually the clavicle. And it's not it's not uncommon for this to actually snap, and then it allows this baby to be born. This heals very quickly. They don't need surgery. They don't need any sort of uh, pinning or anything. It's just usually a green stick fracture because their bones are so soft. But this is one of the ways that this will now be able to fit through here. And this is an actual shoulder dystocia in process. And what this picture is showing you, well, this baby's got its hand up here, so that's probably not helping. But what we see is the baby comes out and then it kind of pulls back in, and we call that the turtle sign. The turtle sign is when the head is born and then it slips backwards just a little bit because the head has been pushed out with force, but then the shoulder is still up here behind the mother's bone. And so it kind of retracts a little back in, and that's called a turtle sign. NCLEX loves to ask you that question. The turtle sign is a sign of impending shoulder dystocia. And so one of the things we worry about is damage to this brachial plexus nerve. If that happens, this brachial plexus nerve here, it's a kind of a complex of nerves, will actually affect the movement of this arm. And we do see injury to that if we pull too hard to help this baby be born. So one of the tools that we can use is something called McRoberts maneuver. And McRoberts changes the shape of this pelvis. So you can see here when her legs are down, the pelvis is, the diameter is different. And when the legs are up, it changes it just a little bit. Now this picture isn't a real great representation, but I firmly believe, and this is based on some of the information I learned in spinning babies, that this is actually internal rotation. So these knees are together because if you put your knees together, you open the outlet of the pelvis. Whereas if you put your knees out, you close the pelvis. I have some great videos that talk about this on my curated YouTube video list. Also, you can do a little sample yourself, do your own little research, put your hands underneath your sits bones, the bones that are sitting, what you're actually sitting on. And as you put your knees out, what direction do they go? And as you move your knees forward, what direction, or towards each other, touching, what direction do they go? So you can prove it to yourself that it actually works. But closed knee pushing, I believe, is part of what McRoberts is supposed to be. Now, you're not going to find that in the textbooks. This is my own little idea here. But I've seen it and used it, and it definitely helps and gives a little more room. So the other thing that a nurse might do is something called suprapubic pressure. And this is where you're actually on the outside using this fist to try to turn and push this baby this direction so that it can fit through. Now, this is in conjunction with the maneuvers that the provider is doing. I'm not going to go through all of those here, but we are going to take direction from the provider so that we can do it in a controlled, cooperative manner. And so here is the management of shoulder dystocia. Be calm. These are the things that we would do in conjunction with our provider, and hopefully that will relieve it. The very last hope, if we're unable to get this baby out, is a procedure called the Zavanelli Maneuver. I have actually seen it done twice, and both of those babies survived. I mentioned this way back in one of my first videos. I mentioned Ina May Gaskin, the midwife. Here's the Gaskin Maneuver. This is what was named after her, and this is helping a mom turn over onto her hands and knees, onto all fours, and this actually will help relieve shoulder dystocia as well, if she's able to. So again, the causes of dystocia, it could be hypertonic uterine dysfunction, hypotonic uterine dysfunction, so too little or too many contractions, some protracted disorders, arrest disorders, and precipitous labor. So a labor that happens in 3 hours from beginning to end. The baby doesn't have enough time to mold that head or get into a real great position sometimes. And so we can see increased risk of dystocia with precipitous labor. Sometimes if that baby is in a not great position, if you've got more than one, if the baby's very large, macrosomia is a condition that we see with our infant of diabetic mothers. CPD, kind of an old term, Cephalopelvic Disproportion. These are when the head doesn't fit through the pelvis, it's too big. And in our smaller stature women, that's what we worry about. She grew a baby that is bigger than what her pelvis can be. And then how well mom is handling everything. If she is having a little bit of the labor psychosis that can happen at the end, feeling very out of control, and not working with her body, sometimes we can see this contribute to our dystocia. Here is a classic picture. We want the baby to be facing to the mother's back. That is going to be the best way. You can see how it just fits naturally down into that space. And here, occiput posterior, it doesn't fit as well. So the best way to help this baby get into the best position, you got it, movement, 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 and up and out of that bed. That has been found, it has been scientifically proven, we can decrease fetal malpresentation by maternal movement and upright positioning. And this again is just those cardinal movements of labor, cardinal movements of birth that have to actually happen in order for this baby to get out. Showing you a picture of that macrosomia. That's when these shoulders get super wide and are unable to fit through that pelvis. Movement, movement, movement. I cannot stress it enough. And here's a picture of closed knee pushing. This is what I was trying to describe. When you have your knees together, you actually have an internal rotation of those hips that will allow this the outlet to open. Okay, now we're going to switch gears a little bit and we're going to talk about preterm labor. This is regular uterine contractions with cervical effacement and dilation before 20 and 37 weeks gestation. That's the definition of it. So you can have contractions, but if they're not making change to the cervix, it is not preterm labor. Simple as that. Somebody tells you they have a history of preterm labor, you ask if there was cervical change, and if there was, then they are at high risk for preterm labor again. But if there wasn't, then that was just contractions, not preterm labor. This is one of our most common obstetric complications. We do know that infection plays a part sometimes in preterm labor and some other specific disease processes. Not completely understood, but our therapeutic management is trying to predict who's going to have preterm labor. Again, if you have a history of it. There are no clear first-line drugs. Tocolytic is your tocolytics are to stop uterine contractions. Sometimes they will use them short term. There is a whole list of them, and you can look again at the medication video. And we try to prolong that pregnancy to allow the steroids to work. And we often will do prophylactic antibiotics because that may be contributing to the preterm labor. Looking at subtle signs, we want to pay attention to contraction patterns, 4 contractions in 20 minutes or 8 contractions in an hour. Here are a list of the different laboratory tests that we can do. Fetal fibronectins have become popular. We are doing ultrasound to determine if there's actual dilation and effacement of that cervix. So all kinds of different tests that can be done. And then the only thing we can do if it's imminent is to try to get the baby, to try to help the baby mature the lungs by using some corticosteroids in the mom and be ready with a good team. Here are those tocolytic drugs. Again, you're going to see these used in different times. These are the mechanism by how it works. And again, see the medication video. Post-term labor or delivery is after the 42nd week gestation. Now, we hardly in our hospital, delivery hospitals, we hardly ever see 42-week gestation anymore because everyone is induced in their 40th week or their 41st week, but some pregnancies do continue until the 42nd week. We would like to get these babies out because we know that there is a higher chance of fetal demise after the 42nd week, but some pregnancies take longer than others. And you will see it depending on who they're being cared for, either an obstetrician or a midwife, you might see some that carry on into the 40th and 41st week. Some of the other things that we're concerned about is fetal macrosomia, the shoulders getting too big. Also infection, and making sure that the placenta is still functioning. And we do that by our biophysical profile, NSTs, frequent kit count assessment. This is a picture of the meconium from an older baby, and sometimes this meconium can cause issue. It can lead to meconium aspiration syndrome. So depending on the circumstances of the birth, they may or may not do specific procedures, and depending on the training of the facility. But if it does cause breathing issues, this baby most likely will be put into the NICU. And it has to do with the thickness of how thick the meconium actually is. Here are some examples of what the skin looks like of a post-mature baby. They've lost all that vernix, that cheesy substance that covers them, and that's what kept them waterproof. So this is a really great picture. It shows you the premature baby skin, and you can see that this premature baby does not have all the creases down its foot. And then we have a normal term baby, and then we have a very peely post-mature baby. And here's that picture again. You can take a look at it. When we are assessing this post-term pregnancy, again, we're going to be doing those non-stress tests, maybe an AFI, biophysical profile, to make sure this baby stays well oxygenated. Now, some moms choose to let nature take its course and wait until the apple is ripe and the baby is ready to come. If she has good support and good fetal surveillance, there's no reason why she can't do that. Obviously, if it becomes a condition that it's going to be better for the baby to be on the outside than on the inside, then we can make steps to help that labor along. You don't find that often with our current medical model of care. With midwifery care, you will see that more often. And here's how to do fetal kit counts, and a nice little list here, and it's just helping mom pay attention to the baby's movements every day. So continuing on to some of our other obstetric emergencies, we have prolapse, fetal distress, and AFE, amniotic fluid embolus. So with the umbilical cord prolapse, this is when part or all of the cord comes down below the baby before the baby comes out. The key here is we need prompt recognition and then measures to relieve this cord compression. So this is what I'm talking about. The cord drops down below before the baby comes. And the problem is it can become compressed. And we know this is where the baby's getting oxygen. So this is a medical emergency for both mom and baby, more so for baby than mom. Here are some different ways that you might see. We call this an occult cord, where it's just down below the baby's head. This is where it's fully coming down, and it's visible from the outside. And this is when it's just down into the vaginal canal. And then you would not know that's going on until you feel it. So what we might see is changes in the fetal monitor. Go ahead and take a gander at what kind of decels we might see if we are having like with this one, for instance, what kind of decels? I'll give you just a minute to think about that. And if you said variable decels, because you wrote out your veal chop, you were right, because variable decels is what we're going to see when we have cord compression. And this is another thing that we're concerned about with our breech babies, is that sometimes that allows more room for this cord to slip down, or if the baby is very high up in the pelvis, it allows for the cord to slip down. And so these are all things that we are watching for when we're caring for our moms. So if we discover a cord prolapse, this is an emergency, and the nurse needs to take steps to relieve the pressure off that cord. And the way they would do that, gloved hand, putting pressure on whatever the presenting part is to push it up off the cord. We can't tuck the cord back in. I know that's everyone's instinct is just tuck it back in, but you don't want to touch it because you can cause it to spasm. And so we just relieve the pressure. We encourage mom to get into a knee chest or hands and knees position, because you can see gravity then kind of pulls the baby up off of that. And we stay this way until we can travel to the operating room and deliver this baby via C-section. Amniotic fluid embolism is a sudden onset of hypotension, hypoxia, and coagulopathy, and it's because somehow some of the amniotic fluid or fetal tissue, fetal material, has gotten into the maternal circulation. Now, lots of research is happening about this, even as we speak. This is something that has been around, and we're just now starting to understand it a little bit better. We know that sometimes we do see it happen, and moms don't have any issue with it. But then some moms are predisposed, it seems, to have overreaction in the inflammatory response. And it's basically like an embolism from anywhere else, a fat or a blood embolism, and it acts the same way. So our nursing assessment is sudden hypotension, cyanosis, difficulty breathing, seizures, tachycardia, cardiac arrest. If it happens when she's still pregnant, we would start all of our same procedures, and within 4 to 5 minutes, try to do a perimortem cesarean on this mom. Obviously, you're going to need a team of people to do that beyond the scope of this course, but know that that's one of the things that we do train in. And our nursing management is supportive measures to maintain oxygenation. Now, thankfully, this is a fairly rare event, and unfortunately, the mortality rate is 40 to 80%. Now, there have been some survivors. You can find lots of stories about these survivors. This is a particular one that was put on the internet. So it can happen. It's tragic. All the situation is tragic when it does happen. So here are some risk factors for amniotic fluid embolus. Again, that multi-parity, that seems to be a risk factor for lots of things. Advanced maternal age. Here's a risk factor. Induction of labor is a risk factor for AFE. And if women are encouraged by their provider to be induced, then in order for them to give informed consent, they need to know that it is a risk factor for amniotic fluid embolus. I dare say that's not happening in a good majority of the cases. Cesarean section is a risk factor, abruption, placenta previa, a cervical laceration, and a uterine rupture. Thankfully, like I said, it is a pretty rare event. So we're somewhere between 40 and 320 AFEs a year in the United States. This is just a diagram of the pathophysiology of it. You can stop and kind of read through this if you want to know more about it. And there is some ideas, some studies about doing some treatment. This is, again, in the research phases. And so they are using AOK for AFE, and these are the different drugs that they're using: atropine, ondansetron, and ketorolac. And there are specific reasons for these, again, beyond the scope of this course, but just know that there is some research about some medications that can hopefully improve our outcomes. Now we're going to switch gears and talk about placental abruption. We did talk about this in our pregnancy, but now we're going to look at how it affects delivery. So this is an emergency involving the premature separation of the placenta from the wall of the uterus. Risk factors of this are a lot of the same risk factors we've seen. Again, maternal age, multiparity, induction is a risk factor for placental abruption. Drug use is a risk factor. Trauma to the abdomen, hypertension is a risk factor. So the management is going to depend on the gestational age and whether or not the baby is still alive. We are going to have prompt delivery of the fetus, vaginal birth if it's a fetal demise, cesarean birth if the fetus is still alive. Uterine rupture is also an obstetric emergency, and it is usually noted by a sudden fetal bradycardia. And our risk factors are previous cesarean section or any surgery to the uterus. We also see risk factors for uterine rupture in induction and trauma to the uterus and drug use. And now we're going to switch gears again and talk about obstetric interventions. So we have induction, which I've mentioned a couple of times, amniotomy, amnioinfusion, operative vaginal delivery, and cesarean birth. So amniotomy is when a specific instrument is used to break this bag of water. There are benefits and risks to every procedure, right? And a woman needs to know the benefits and risks to every procedure. Sometimes this is done so that internal monitoring can be done. There's some evidence that by breaking this bag of water, we have increased prostaglandin production, and that might encourage labor to get going. When the head pushes up against the cervix, it causes an increased release of prostaglandins. Most of that research says it might speed up labor anywhere from 30 minutes to 2 hours. Some of the negatives are you now have broken the barrier in between mom and baby, and it is an increased chance of infection. And it's once you've done it, once that water is broken, there's no going back. So if the labor stalls or if contractions don't continue, then we now have to think about doing the next step, because we can't just send them home with their water broken. The difference between labor induction and labor augmentation: induction is making contractions by a surgical, medical means. So we're causing things to happen by either meds or by some sort of procedure. An augmentation is enhancing ineffective contractions after labor's already begun. Here are some indications for augmentation and or induction. This is something called a Bishop score, and it's one of our scoring systems to determine how ready that cervix is to be induced. So a Bishop score should be calculated for every woman coming in for induction, and evidence tells us that that Bishop score needs to be upwards of 6 in order to increase her chance of having a vaginal delivery. If it's below 6, she's going to need some cervical ripening before she's ready to actually have an induction. And we use that with different techniques. So the cervical ripening, we have some medications, prostaglandins, that will help encourage the thinning of that cervix and get it ready for labor. We have some mechanical methods, and we have some pharmacological methods. I'm going to show you that in just a minute. We also have our medications that will cause uterine contractions that will hopefully ripen that cervix. So there is some practitioners that are still using oxytocin in this way. There are some herbal agents. I'm sure you've heard about them. And you have probably heard about castor oil and enemas as well. There's some research out there that these do work, although if someone is doing these at home, we have no way to know how well the fetus is tolerating it. And it should be used with a provider, usually a midwife, and their oversight. So this is Cervidil, that flat little tampon that sits right up there behind that cervix. It's a 12-hour medication that is meant to increase the readiness for labor. It's not meant to put you into labor. A few people do go into labor with it, but it's really just meant to get that cervix ready. So this is one of our means of cervical ripening. And then here's that Pitocin again. Here's our dosages, low dose and high dose down here. Remember, Pitocin is a high alert double check. This is what it does. It is not the same thing as our naturally occurring hormone, oxytocin. They are different. It is similar, but it is chemically different. And every patient that is receiving any sort of synthetic Pitocin needs to have a pre-use checklist and a frequency, every 30 minutes, we need to be looking at these criteria to make sure that they are still eligible for this medication, because we don't want to be causing the baby stress with this medication. And it is the labor nurse's responsibility to confirm that all of these things are in use. And I will tell you, a good majority of our court cases that are out there for fetal distress and lack of oxygen do have Pitocin involved. And then mechanical induction, this is mechanical ripening. This is a specific type of tool. It looks like a Foley, but it has two balloons on it. This one's called a Cook's balloon. And it is put in by a provider, and that will actually put some mechanical pressure against that cervix. And by the time she's 4 centimeters, it will just fall out. And so this is kind of a lower invasive way of ripening that cervix. Amnio infusion. This is a procedure that can happen for a couple of things. This is an internal monitor that is placed by a provider, and on this internal monitor, it allows us to be able to connect IV fluid, and it's the fluid that we typically use for an IV, and it will flow fluid back up into where the baby is. So we might do it for severe variable decels due to cord compression. Sometimes it's done for oligo. Sometimes it's to wash out that meconium. So this is something that you do see occasionally. I don't see it used as much anymore as I used to. It's put in, this is that internal monitor. It's called an intrauterine pressure catheter or an internal monitor. We also have the ability to do an internal monitor on the baby using this scalp electrode that just is tucked in just underneath the skin. Oops. And this is another procedure I don't see used as frequently as I used to, but this internal scalp electrode is going to give us a very accurate reading of the baby's heart rate. Now, there are cons. Again, there's pros and cons to every intervention. And so one of the cons to both of these is the increased chance of infection, because now you have a superhighway for those bugs to travel up. So again, informed consent needs to be given for each mom and her partner, and then we respect whatever decision it is that they make. So an operative vaginal delivery is when their provider uses forceps or vacuum, and that's to apply traction to the fetal head. Their indications are listed here on the screen, and there is always risk. There's risk of tissue trauma to both mother and newborn. And usually these are used when it's an urgent situation for this baby to come. So baby is showing us it's going to be better on the outside than on the inside based on the heart rate. And so a vacuum might be applied. There are rules associated with using these vacuums, the amount of time it can be applied, the amount of time we can, the provider can pull, how many pop-offs, how many times it pops off the skin. And we always need an exit strategy if one of these are going to be applied. Sometimes you will see this used for maternal fatigue as well, because just at the end, she just has no more energy to help push this baby out. And this is what it looks like. It can cause some pronounced molding of the head, but again, this baby's head is nice and soft, and it should be back to normal very quickly. The other potential side effect of this is cephalohematoma, so we need to be on the lookout for that and assessing for that if a vacuum has been used. So this is something that we would pass on and report, make sure that the next nurse is also watching for signs and symptoms of that. And this just is what it looks like as the vacuum is applied to that baby's head. And as the mom is pushing and bearing down, the provider will apply traction. These are forceps. They're not used nearly as much as they used to be. And this is an instrument, same idea as the vacuum, except they're a little more invasive. And these actually lock together. They attach around the baby's head, and they're used to pull as the mom is pushing. And then we have cesarean birth. And when we're thinking about cesarean birth, we're moving from normal labor and delivery and the expectations to a surgical patient. And so we have to think about pre-op care, intra-op care, and post-op care. Cesarean sections have definitely been on the rise over the last 30 years. In fact, they've risen over 60%, interestingly enough. And we think about cesarean sections, the increase, we think, well, it's probably because we want to improve our outcomes for our moms and babies. We want to have less cerebral palsy, which is related to lack of oxygen in delivery. And we want to get these babies out sooner when we notice that things are going wrong. But even though our C-section rate has risen 60%, our cerebral palsy rates and neonatal seizure rates have remained unchanged. So what that means is we're using cesarean sections very judiciously, and we haven't seen any changes in our outcomes. If, depending on where you live, you might have a higher C-section rate based on the state that you live in. So if it truly was needed in our society, that should be the same color all the way across the country. And look down here in some of these states. You have really high chances of having a C-section in some of these states. Again, these are the reasons that we see increased C-section rates. A good section here, labor arrest, meaning labor started and then it stopped. A lot of times people that are failed inductions, meaning we try to induce that labor and it doesn't happen, we call that labor arrest. Malpresentation of that fetus, good percentage of why our C-sections are happening. And then non-reassuring field tracings, meaning that baby's telling us there's not enough oxygen. So the biggest part of the reason for our C-sections is here and here. And these are things that as labor and delivery nurses, we have influence over. The other reason that we see a higher cesarean rate is because we have a pervasive tolerance for increasing technological childbirth. We've just accepted in our society this is the way we do it, including the casual acceptance of cesarean birth. So let's talk about some of the risks. Cesarean is not without risks. All of these things that are listed here are acute risks for our moms. We have long-term and subsequent birth risks associated with increased cesarean section. And we have increased neonatal risks. In fact, the number one reason that babies are taken to the NICU is not being able to breathe properly, so having issues with oxygenation. And we do see impaired neonatal function, respiratory function, with cesarean sections because they don't get that squeeze and they have lots of fluid in there. And we see a higher percentage of these babies going and needing some care in the NICU. Nonetheless, cesarean births are also life-saving and they have an absolute role in our obstetrics. We just need to send this message. They shouldn't be taken lightly. They shouldn't be used as frequently as they are used, and we can do better. Now that we know better, we can do better. Here is an example of cesarean birth, and this is what they call a gentle cesarean birth. And this mom, if she chooses, is able to actually peek down there and see her baby's birth happening. Now, not everyone is down for this. Not everyone wants to see the surgical part of this, but for some people, it's very important for them to be involved in that process. And we should make this available to whoever wants it. We have to not forget that this is her birth as well. She's just as excited and happy to meet her baby, and she's bravely undergoing a major abdominal surgery in order to do that. So making sure that they get good skin-to-skin contact, that if she wants to breastfeed immediately, she can. Trying to bring this mom and baby back together as quickly as possible should be our role as the nurse. And many places, the labor nurse is also a circulating nurse in the OR. And using that snuggle time after delivery while she's in recovery is super important. And here is what it looks like as a baby is actually coming through that incision. This one looks like it's a pretty large incision, but it's not. It's just because this baby is coming through. They have what we call a classic incision and a low transverse. We prefer the low transverse, and this is what you've seen most often in the last 30 years or so. Sometimes in other countries, or if the baby was extremely premature, or it was an extreme emergency, you might see classic, but not very often. The type of closure is going to depend on your provider. So that is something that a mom needs to have that conversation with the provider of what type of closure she expects to have. And then there's vaginal birth after cesarean. All of the major groups, ACOG, A1, ACNM, have come out and said vaginal birth after cesarean is appropriate and is a safe option. And there's a lot of controversy related to the risk of uterine rupture and hemorrhage. And so some physicians are not comfortable with it. Some hospitals have some very restrictive rules about it. But if a mom has had a previous cesarean and is looking for a vaginal birth after cesarean, and it's not just one and done anymore, if you've had more than one cesarean, there are providers that will still consider a vaginal delivery. They need to just search for the right provider. We as nurses can look at the evidence, look at the research, and advocate for our patients. And here is a great article that's done, talks about the myths of vaginal birth after cesarean, and it has all of these references, so you can spend some time here if you'd like. And then demise. This is one of the things that as labor and delivery nurses, we don't advertise that this is a good portion of our job, but it's probably one of the most important things we do. We don't often know why the baby has died. It's devastating, especially because it's usually found out suddenly. Mom's not feeling the baby move. She comes in for a well baby check and we don't find a heartbeat, and it progresses from there into induction and delivery. This can be an overwhelming process for both the family as well as the nurse. It's one of those things that everyone in the unit will be supportive of each other. We all back each other up when this situation is happening. You will obviously have clergy if the family wants, and social services, and we try to make it as painless as possible, both emotionally and physically. And we do often have keepsakes, memory boxes, photos. Sometimes people do molds, clay molds of hands and feet, that sort of thing. We do pictures and provide them to the family. I've mentioned these before. These are actually gowns that are made from donated wedding dresses by a specific group in my local area. I'm sure they're everywhere. And these are amazing because we're able to take them off and put them into the keepsake box. So this is still a delivery. We still have all the things that we need to be doing for the mom. And we just unfortunately have a sad ending rather than a happy ending. This is the only experience and time this family's going to get with this baby, so we don't rush them at all. And we try to include siblings if that's what they want, of course, grandparents, that sort of thing. And I can't leave you on that note. So I love sweet, sweet babies in cute hats. Here's a couple of pictures of them. I appreciate your time. If you have questions, put them down in the comments. I know this was a long one, and thanks so much.